I hope that in the next 20 minutes I can give you food for some thought and maybe even change your practice. And I'll start by saying this. Here's something to keep in your head. Know your lions. I'll come back to that a little bit later. So let's take a real case. Here's a lady. She's got a weak positive endomycel antibody. You can see that she has villus atrophy in the biopsy, and her symptoms are not getting better. So what happens next? What would you do? Well, what I did was a colonoscopy. And of course, this lady had Crohn's disease. So I went back to my immunologist and I said, Bill, this lady had villus atrophy on her biopsy and she had a weak positive endomycel antibody. What do you think is going on? And he said, oh, Dave, weak positive, it's immunofluorescence, it's subjective. Hey, let's call it negative, shall we? And my point is an important one, which is actually, when you start with people with persisting symptoms, think about what the diagnosis is. Serology negative villus atrophy, yes, the most common cause for that will be celiac disease, but there are a host of other causes, and it may even be transient. You as clinicians are familiar with antibody negative celiac disease, probably accounts for about 5% of the cases we see. Why does it happen? Well, it may happen early in the disease. Maybe they're not quite immunologically up and running, perhaps late in the disease when they're overwhelmed. IgA deficiency is something to be aware of, so ask for an IgG titer of tissue transglutaminase if you've got clear IgA deficiency. Celiac disease, as you know, is an autoimmune condition, so if you've got other autoimmune conditions that are connected, and perhaps that patient at the time of testing is on immunosuppressive therapy, you may get a negative result. Again, family history, first-degree relatives, they may have histological changes, but negative serology, and I think that's, again, an early feature. And finally, probably the most common thing, which is patient is waiting for test, patient chats to everybody and decides to start a gluten-free diet before they actually come. And so you have to be aware of this, and you have to have your eye in. So I think, for me, the first thing to emphasize when dealing with persisting symptoms is, what is the diagnosis? Is it celiac disease? Do they really have positive serology? Did they have villus atrophy on a biopsy? And sometimes HLA can be very useful as well. DQ2 and DQ8, as you know, are actually present in virtually everybody with celiac disease, probably about 25 to 40% of the general population. So if your patient has got negative serology, villus atrophy on a biopsy, and a negative HLA DQ2 and DQ8, it makes celiac disease pretty unlikely. It's a good negative predictive test. So I think that's step one. So here's something that I really want to dwell on. I've put a construct up here of, I think, how we view people who have celiac disease and how we manage them thereafter by looking at serology. And I want to challenge this construct. Look at the top left-hand side, and there's this fantastic paper by Jeremy Woodward. So imagine you're a clinician and you do your tissue transglutaminase and the patient has got a positive TTG. Well, historically, you'll have said, you're very naughty, you need to try harder. But if you look at Jeremy's study, actually, not all of them will have villus atrophy on a biopsy. Historically, if you do the TTG and it's negative, you'll say, what a very good patient you are, you must be doing very well. But in fact, a quarter of them will have villus atrophy on biopsy. So I don't think serology is the marker that we have thought it has been cracked up to be. And here is further data from our own group looking at 200 patients. And I want you to look at the right-hand side, what's encircled in red. This is the likelihood of these tests, serological tests, point-of-care testing, or the validated adherence questionnaires that you're familiar with. This is the likelihood of them detecting villus atrophy if you apply that test. And you can see the sensitivity is shocking. It's very poor. Why is this important? It's important because the only gold standard that we have is villus atrophy. The studies that are out there suggest that persisting villus atrophy has a relationship with complications, long-term reduced bone mineral density, higher likelihood of gastrointestinal malignancy, particularly lymphoma, more likely to have hematinic deficiencies. So this is the only thing that we can properly hang our hat on. And of course, nobody thanks you for that second biopsy, but I'm trying to make us think about this. Here's another important concept in this debate. Here what we've done is put up studies where they've undertaken a repeat biopsy, and if you follow the lines, you can see that with the passage of time, you have higher levels of remission. You are more likely to have a normal biopsy. And so the point here is that it takes time. There will be slow responders in your cohort, and somehow we have to figure out how to manage these individuals. This is what I'm hoping will be the future. All the patients, understandably, would love to have a non-invasive test. And I think, and I hope I've convinced you that what we have currently is inadequate. But gluten immunogenic peptides, which are present in the urine and the feces, they may be the future. The data that's out there is suggesting that they're very sensitive, and if this can be validated and we can show that they have a good relationship with the persistence of villus atrophy, then these may be the perfect tests for us to use and adopt in our clinical practice. Now, word of caution, if the patient changes their diet, if they're not adherent, but they decide to be for a few days before the test, it will be negative. But I still think that's in the patient's hands. We can only try and explain to them the benefits of going with their gluten-free diet. So let's come back to the construct of investigating people with persisting symptoms. I'm suggesting that if someone comes to you, then you're committed to a second biopsy, once you're sure that they have celiac disease. What do you do if they have a normal biopsy but gut symptoms? Well, we and others have shown a few things that are worthy of mention. The first is if you have reflux-type symptoms or other gastrointestinal symptoms and a normal biopsy, it's worth treating these. You'll actually improve the quality of life of your patient. And now we're seeing the emerging role of the FODMAP diet for these individuals. So they're already on their gluten-free diet, and then you just lower the number of FODMAPs, and that will take away some of these functional symptoms, just as you would in irritable bowel syndrome. So it's analogous, and it's well worth doing, and it works for your patients. You can see in the top left-hand box, I've laid out a sequence of tests that you may run through for patients, of course starting initially with the repeat biopsy. And then on the right-hand side, I've put down what the potential conditions are. So let's just highlight that for a moment. I've highlighted two conditions, microscopic colitis and exocrine pancreatic insufficiency. And my reason for doing these two is because actually the data for these being associated in people with celiac disease is quite strong. If you have somebody with persisting symptoms, you undertake a colonoscopy, it looks normal, you take biopsies, you will get back microscopic colitis, probably at a level of about 5% in individuals with celiac disease. And these individuals will benefit by using budesonide or prednisolone to improve their symptoms. And really all it is lymphocytic involvement of the colon. The same lymphocyte that is the insult in the small bowel is doing something in the colon. Exocrine pancreatic insufficiency has been well shown to be associated in individuals with persisting symptoms. We're not quite sure of the mechanism in individuals with celiac disease, if it's related to malabsorption or an autoimmune drive, we're not sure. But certainly doing a fecal elastase, seeing if it's low as a marker for this condition, and then giving them adequate doses of pancreatic supplement, and by that I mean something in the range of 150,000 or more, will improve those symptoms. The other things which I've listed are either unrelated to celiac disease, but you've got to have your eye and throw a large net out and don't get fixated on the celiac disease, or things that might be related to persisting villus atrophy, such as bacterial overgrowth or lactose intolerance. The data is less convincing, but again, it's things that you may think of. And in my mind, I work my way through that first box in the top left-hand corner and try and concentrate on what comes out of that box. So this is now my view of what I think is persisting symptoms. It's the biopsy approach. So of course, if you're in the top left-hand corner, fantastic. You're in remission, you're doing well, no problem. Top right, That might be the functional symptoms that I mentioned earlier on. And then you've got the bottom two groups where you still have abnormal biopsies. And that brings us to the issue of whatever we want to call these conditions: non-responsive celiac disease, arbitrarily termed patients who have persisting symptoms on a gluten-free diet, and refractory celiac type 1 and type 2 that you've heard of. And I'd like to spend the next few slides dissecting this out. So I think the first step in the presence of persisting villus atrophy is to involve a dietitian. And for me, they're the most important person in celiac disease. Everybody else is inconsequential. It is a disease where the cornerstone of treatment is through diet. So that's the person we want involved in patients' care. But we have to be mindful the patient may inadvertently or advertently be not adhering. It's dependent on the patient themselves. Each case is different. And then I've mentioned to you about slow responders, and of course there are those who are super sensitive, and even the gluten-free diet alone will not be enough for them. So we need that careful, really meticulous dietetic review. And then, if we've done that and we can't find anything and the villus atrophy continues, we start to think about this term of refractory celiac disease. What does that mean? Highlighted in the left box are all the different complications that we read about, and the first thing I want to say is they are all pretty rare, but they have a high mortality attached. And the way to distinguish refractory is by looking at the percentage of abnormal cells. So I mentioned to you several times about lymphocytes, and these are aberrant lymphocytes. Generally, the response in celiac disease is a polyclonal one, but here they develop a specific lymphocyte population. A monoclone comes through, and you can look at this either doing flow cytometry or immunohistochemistry, depending on which center you're in. But there's a very important clinical point. Patients with a new diagnosis of celiac disease, it's possible for them to have a low-level monoclone. Patients who are not adherent, it's possible for them to have a low-level monoclone. So that can bounce around. You need longitudinal follow-up. You need repeat biopsies. You need to look at their diet carefully. And we need to be very careful about how we handle these patients, because often, once that word refractory is mentioned and that patient goes home and looks at the internet, then you're dealing with a very different individual because they are terrified by what they read. So here, what I've done is summarized all the literature of the current published studies. And you can see on the right-hand side that the outcomes, when you subdivide from type 1 and type 2, the outcomes are appalling for type 2. Worse than pretty much any cancer that you could think of. Most of the people will be dead within 5 years. So what's happening in the UK? In the blue is Sheffield, and you can see that we've put in all the patients that we've seen from around the UK, and of course the largest numbers are diagnosed locally. But what we've done is work through all these cases, more than 2,000, of which more than 200 had come with persisting symptoms. So what is the breakdown? Broadly speaking, it fits with what I've said before. Number one cause is a problem with adherence. Number two cause are functional gastrointestinal symptoms, so normal biopsy. And then we've got RCD1 and RCD2, and of course a host of other things. And the important point that I'd make is that these people have come from across the UK, so it's a skewed cohort. Can we get a feel for them? Well, I think we can. I think the RCD2 group are more likely to be a bit older. They're more likely to present and rapidly deteriorate. They're more likely, probably, to be male. So you're starting to get a sense of how it works with these individuals. What happens next? This is a Kaplan-Meier survival analysis curve. And to make sense of this figure, as the line falls, people are dying. So if you look at in blue, you've got RCD1. And then look at what happens to the RCD2s. The mortality is staggering. The outcome is awful. It is actually, in many ways, presiding a death sentence once you've seen that, because our treatments are useless. So, know your lions. Does anybody know these lions? Do you know the one on the left-hand side?
Mufasa.
Is that really Mufasa? Yeah, you're right. And the one on the right is Scar, okay? So these are two lions. They're brothers. They're both lions. But we all know they behave very differently. And what I'm suggesting to you in your clinical practice is when you see somebody that you think has refractory celiac disease and your instincts are telling you something, the likelihood is that there is something very bad happening. And you have to be aware of that. You have to look at the clinical picture. I'm pleased to say that we are now the National Centre for Refractory Celiac Disease. It's a hub and spoke arrangement with my colleague Jeremy Woodward in Cambridge as the spoke. And we're trying to offer a service across the UK, and we're more than happy to offer second opinions, review of the notes. We will see those patients as well. I think one of the very important things that we do is distinguishing between RCD1 and RCD2 to ensure that those patients who are RCD1 actually, it almost takes away the burden of their fear. And of course we use the various treatments, and what we're trying to do is to centralise our knowledge and to have shared care, but bring in some of these new therapies like stem cell transplant or interleukin-15, because the outcomes are appalling, as I mentioned. So I'll draw this to a close by saying these are the Mufasas of Sheffield. In the picture there are all the fellows. Nothing happens research-wise without that group of people. They're absolutely fantastic, and some of them are sitting in the audience today. And then on the right-hand side is Lizzie Baggas, who's a medical student who actually has been running this whole database for a year now and put together all of this data. So these are the people who did all the work that I've just presented. I'm nothing more than a front man. Thank you.